Thanks, everybody, for joining. We are quite spread out for a pretty big room. If people want to consolidate, it might make things easier both to listen and for the speakers to also address, and for the mic givers. So let's do that. Yep, integration. That's a nice one. Awesome. So just to make sure you're in the right room, this session is about integrated services for greater reach. An exciting topic for sure. We have two very, very practical examples, one from Madagascar and one from Lebanon. And we have two eminent speakers here. So we've got Dr. Chizoba Wonodi, who is an associate scientist at the Johns Hopkins Bloomberg School of Public Health. She has nearly 3 decades of experience as a public health physician and is a known person in the immunization field and recognized leader. She's currently serving as the director of immunization for the USAID-funded Momentum Country and Global Leadership Project. Dr. Bhrigu Kapuria is an experienced medical doctor and public health specialist and is currently serving as the immunization manager at UNICEF Lebanon's country office. With over 2 decades of experience in the field of public health, he has expertise in various domains, including immunization, reproductive and sexual health, HIV/AIDS, and operational research. Within immunization, Dr. Kapuria has excelled in enhancing coverage and equity, managing vaccine logistics, and cold chain integrity. He's also demonstrated proficiency in cholera outbreak management as well. So quite a diverse space. Let's give a hand to our speakers. And with that, Dr. Chizoba, over to you.
Thank you so much for the introduction. Good morning, ladies and gentlemen. I'm here this morning to speak to you about a study that my colleagues and I are doing in Madagascar. And that's the list of my colleagues here. Some of them are in the audience. Shout out. Yeah, so what we set out to do is to try to understand the relationship between zero dose and wasting. If you are familiar with the discussion and the conversation in the zero dose community, there is a popular saying that goes that the zero dose child is also zero dose for nutrition, is also zero dose for wash, zero dose for education, everything. So we are part of the USAID-funded Momentum Country and Global Leadership Project. So we are providing technical assistance to different countries to strengthen their immunization programs. And so as part of our work supporting Madagascar, we wanted to examine that question, right? And the reason is very clear. We know who the zero dose children are, so I don't need to define that. But we also know that they are likely to face multiple deprivations, and that exacerbates the vulnerabilities that they have. So for Madagascar, they are one of the 20 priority countries that USAID, that the WHO and IE 2030 have sort of identified for really intensive action to catch up following COVID. So this is a really good place to explore that question. Then, excuse me. So for our team, this is one of the things we're doing in Madagascar. This study, therefore, specifically to answer that question, what we try to do is to describe the prevalence of zero dose. So the same questions that were explored in the earlier presentation. How many zero dose children are there? Where are they? And why are they zero dose? The other thing we tried to also do was to look at the co-occurrence of zero dose and wasting. We selected wasting as a marker of malnutrition because it's the is actionable. Stunting is less actionable than wasting. So that's why we selected it. And then we also wanted to look at the drivers of zero dose and wasting. Are they the same? Correlates. And then finally, we wanted to look at the so what. So, what are the challenges with identifying solutions and implementing solutions to address the dual problems of zero dose and malnutrition? We did a what we may call, a mixed methods study. The first method we used is DHS analysis. I'm not going to go into the details because of time. So with the DHS data, we looked at prevalence, we looked at correlates. Then we also did human-centered design with stakeholders in Madagascar to explore with them what the health system challenges were and what the solutions might be. And then based on that, we are now designing an intervention to improve integration of the services for immunization and malnutrition in the country. So I'm going to present findings based on 4 objectives that we set out to explore. So the first one is, where are the zero dose children and how many are they? What we found is that 18% of the children in the age group that we looked at, which is 12 to 35 months, were zero dose. And about half of those children, half in terms of proportion, were wasted. So more zero dose than wasting. In terms of the co-occurrence of zero dose and wasting, we found that only 2.2% of the children were both zero dose and wasted. So on the question of, are the zero dose children also the ones who are zero dose for nutrition and all, that wasn't particularly borne out at the individual level. So we then also looked at, what about zero dose and nutrition in the same, what's the prevalence of zero dose and nutrition, zero dose or nutrition in the country? And we found that 1/4 of the children were either zero dose or wasted. So that's a high prevalence of either outcomes. Then we looked at the regions to look at where they are concentrated. What you can see here is that at the perimeter of the country, you find that that is where they have the highest prevalence of either zero dose or wasting. And the box, look at the bar graphs there. Though there are 11 regions that have a prevalence of either of those two conditions more than 30%. And so that begins to tell you where the concentration of the problems are and where we might, as program people, begin to prioritize. The next thing we did was to then create typologies of these two outcomes, where we have this quadrant, and we then classified the regions into high zero dose, low zero dose, high wasting, low wasting. The idea here is that if you have limited resources and you want to focus your attention, where would you get the biggest bang for your buck? Looking at the two different types of interventions. So in the second quadrant, the number 2 quadrant there, that's where you have the highest risk of both zero dose and wasting. So if you wanted to intervene, you would focus there. So that's what we did, and then shared these findings with the EPI team. Then the other thing the other question we wanted to ask is around the correlates. What's associated with zero dose and with wasting? So we used the available indicators in the DHS, noting that there are some limitations to the variables that we could find. And then what we see from our analysis is that, just look at the boxes there, you see that there are more factors associated with zero dose than with wasting that we could see from our analysis. And where you have sort of the same factors that are sort of lighting up for as risk factors is really on maternal education. Back again to the question that was raised in the last session about maternal education. So it's a risk factor for many things. So in terms of weighting the different kinds of correlates, what we can conclude here is that the correlates of zero dose relates more to health access than anything else. And for wasting, it's really maternal factors really that light up for wasting. Then we also looked at whether or not wasted children have more access to vitamin A than zero dose children. And what you can see here is that certainly the zero dose children are also displaying lower access even to vitamin A compared to wasted children. So vitamin A access is not the same as food access. So kids can have access to vitamin A and still be wasted and still not have enough food. Part of what we did also was to do human-centered design workshops to co-create solutions with the stakeholders in country. And what we explored were really around the current status of integration, because if we see that there are regions where you have high rates of zero dose and also high rates of wasting, then it makes sense to integrate the services. So why are we not integrating services? What's the current status of integration of services? We found that it was a mixed bag. There were some places where services were integrated and others where they were not. And some of the key barriers there had to do with what we've known for a long time. It has to do with availability of health workers. It has to do with maybe lack of policies and guidelines, and also inadequate resources and materials. We then looked at the recommended actions from the human-centered design workshops and categorized them into things that we need to do to improve coordination. So integration has to be looked at as a multi-step process, right? So you integrate at the coordination level. The immunization people should be talking to the nutrition people. And one way to do that is to have joint meetings, either monthly meetings or thereabouts. The other thing we can look at is leverage opportunities for partnerships. So if you recall, in the graph, in the map of the country, there were some areas where you had high concentration of zero dose and wasting. And in those places, some of those places where you had high wasting and zero dose, they also had food security programs that we know have more robust logistics support. So one of the solutions that came up was that we should explore integration of both immunization, nutrition, and food security programs to make sure services get to these kids. And then we also talked about developing a roadmap for integration of immunization and nutrition services, which is what our team is going to work on going forward. And of course, training healthcare workers and then providing nutritional supplements to caregivers during immunization services and creating demand for immunization so that parents know that when they come for immunization, they can also get nutritional services and vice versa. So I think I'll end here by saying that we found a high prevalence of zero dose, and then not so well, half the prevalence of wasting in the country, but 1 in 4 children are either zero dose or wasted. So this means that we need to really strengthen integration of services and really identify the models that will work and work beyond just immunization and look at food security programs as potential allies in ensuring that services get to children. So thank you very much. My time is up.
Good morning, everyone, and thank you for joining in. In the next 10 minutes, I am going to take you through a journey where the concept of immunization as an entry point, which has been very clearly defined under the IA 2030, how do we practically roll it out, and how do we bring in the experience from a country from Lebanon, a small country in Middle East, that how can immunization be an entry point not just for primary healthcare, but beyond healthcare also. So it's a practical demonstration example of how can we take it forward. Let me start by bringing in the context. The context is very important. Lebanon is a small country in the Middle East which has been going through extensive crisis for the past decade or so. It was an upper middle income country with a GNI of 7,000 per capita. In 2011 to 2013, the crisis of Syrian refugee crisis started in where nearly 1.5 million Syrian refugees were accommodated inside it. Uh, just to set the context, Lebanon is on the verge of, you say, per capita or on the population density. Lebanon hosts the highest number of refugees in the world when you talk into areas inside. At this point of time, there is nearly 1/3 of the population which is from the refugees inside the country. So it's a large chunk that the country is hosting. This was going on, but in 2019, the country went through the worst economic crisis. The World Bank defined it as the worst economic crisis of modern times since 1850s. Which led to collapse of systems, which led to collapse of different things. And in 2020 came the Beirut blast, if you might have heard. This is defined as the biggest non-nuclear explosion on Earth, which killed 200 plus people and had an impact of shock waves of 2.6 Richter scales reaching up to Cyprus. This also was not just a blast, it destroyed the entire economy because it has a very clear component. The port was gone, the entire shipping industry was gone, the associated factors that were gone, which led to a continuous financial collapse that was happening. In between came COVID, which also triggered across the entire tourism industry. So there were series of collapse that were happening inside the country, and you might have been seeing that Lebanon has been in news for the past 2 weeks on a different reason at our southern borders. What was the impact of that? The impact of all of this was, if you see that 70% of Lebanese and 90% of Syrian refugees are now living below the poverty line. The entire effort has reached that where the inflation rates touched around 260 in 2023, and the local currency lost its 98% values. So the government funding and the government budgets became dust. The purchase power became nothing. And this led to basically World Bank decreasing it from an upper middle income country to a lower middle income country. And the entire effort is now further complicated with an absence of a government. There were elections that held in May of 2022. Still now there is no government, there is no parliament, no president, and a caretaker government is taking care of. So this is the entire background. This background has a very clear impact on the health and on immunization services. Considering this, Lebanon was considered the medical tourism hub of Middle East. People used to come to Lebanon to get the best of medical services. But when the economic crisis hit, 40% of the doctors and 30% of the nurses moved out of the country. These are the best qualified people who were moved outside. But what led to is a private sector driven system suddenly crumbling across. You don't have access to that. And the impact of that was very clearly visible on immunization program as well, which suffered a 30% loss in the public sector vaccination and a 50% loss in the private sector vaccination. These efforts are very clearly visible with recurrent outbreaks of measles that is happening in 2023, much in the numbers as compared to 2020, 2021, 2022. The situation is that every third child in Lebanon is practically not vaccinated with even a single dose of measles vaccine. So our 1/3 of the children who are born in the past 3 to 4 years have not been given one dose of vaccine. In addition to that came the cholera. After 3 decades of no cholera, cholera came back in a crumbling health system. The cholera created its own, the entire system that was already crumbling over there. There is no fuel. So the electricity became a problem. In Beirut, in the capital, the grid electricity supply is 2 hours per day. You can consider what is the electricity supply. So the health facilities had the challenge to now convert fridges into either gas or kerosene run things or run them on diesel generators. PHCs were going dark, and preventive efforts or preventive things have taken a backseat for the parents because they were struggling to bring bread to the table. So getting child vaccinated was a back-end strategy. I will talk about that later on. And just to bring in the perspective, as I said, 1 in every 3rd child is a missed child, 1 in every 10th child is a 0-dose child. Coverages of a very good system going down to things. So in this entire thing, what is the strategy? What was the strategy? UNICEF worked with Ministry of Public Health and with our partners, Lebanese Red Cross, to come together a strategy where we focused on 2 interventions. One was the intervention on primary healthcare settings, and the other intervention was on outreach. So we strengthened the primary health systems by bringing in practical capacity building of nurses, because these are new nurses, recently graduated during COVID time, having limited skills on dealing a child of 2 months of age, giving them vaccine. So practical training. Second was on solarization. We extensively impacted on solarization of PHCs. I'm happy to report that the entire PHC network in Lebanon is now working on solar energy. The third thing that we did was on solarization of cold chain. We deliver vaccines around 800 points. So the entire network of cold chain from the national level to the last mile is now running on solarization or solar cold chain equipment. So we will be practically maybe one of the few countries in the world who has converted their entire cold chain network on solarization. These were steps at the facility level. The second steps were at the community level, where we brought systems together. We did the outreach at the places of PHCs or at the rates of panchayat. But this is a known story. This is what all immunization teams know. You do health facilities, you do outreach. What was different? What was different was immunization as an entry point. And I can tell you this was not by design. This was by moving across piece by piece and then realizing that our primary target of getting children vaccinated can do more. So what we did was we started with saying, whenever a child and a parent is coming to get their vaccines at the outreach, this is a missed child. So from the previous presentation, you can very well realize that a child who's a missed child has also missed across all the other services. So what we designed was we started saying, if this child is coming in, can we do something on malnutrition? So we initiated a small protocol that when the child is coming in, children between 6 months to 5 years of age, all were screened with MUAC tapes. Children who were there, who were identified as underweight, SAM or MAM, were then referred back. I will like to clarify that we are talking about immunization as an entry point, not immunization as a final service delivery. So what it was doing was bringing across and then linkages. So children who were identified from that, missed children who were SAM or MAM, were linked to the malnutrition program. So we have a tie-up, we have a follow-up that is happening. The second thing was out of school. UNICEF played a big role in getting the school education. But these children who have missed their vaccines were also children who were out of school. So we started looking into children who are out of school, and I'm asking just a simple question: why are you out of school, or by what time? Is it financial? Is it discrimination? Is it access? And then these children who were identified who were out of school were linked to the school program, which actually goes across looking into these children. The third was Kudwa, which is our child protection system. So we also realized that vulnerability in these circumstances is high. So through a storytelling message, when the parents were there, we started bringing in features which is on child labor, on domestic violence, on things in a story narrative manner when children and parents are over there. So you bring in the child-centered. Then was our Hadi program. Hadi means basically being close to you. So Hadi is it's a cash grant that is provided to the most vulnerable population. Here we use this as a dual methodology. What we did was we reached out to children who are enrolled into Hadi program. That means children of the most vulnerable families, and then reached out to say immunization is happening in your area. And then we tracked how many of these Hadi children are actually coming. This proved us two things. This provided us with the opportunity to provide integrated services, the most vulnerable children, and it also provided us with the opportunity that we are at the right place because we are reaching the most vulnerable population. Next was disability. We realized that when in these circumstances, children who are disabled are left at home. They are not brought to the health facilities. They are not brought to sessions. So we had a special intervention where our partner Lebanese Red Cross knocked every door, identified children who are disabled, created right places to make these children come across to the services, and therefore you integrated disability inside that. These disabled children were also then linked to programs which were providing services for artificial limbs, for surgeries, for things. So again, you have a very clear entry point to provide disability. Then was early childhood development. ECD, there is no other program that reaches a child early than immunization. We reach the child at birth, we reach the child at 2 months, 4 months, 6 months. So when you talk about ECD, immunization became a very clear platform to educate mothers, to help nurses to identify danger signs. So you can identify developmental delays and then again refer back to the right people who are there at the PHCs. Then is the entire consortium of maternal and child health. So bringing mother, because mothers were there, so have a very clear discussion around age-specific intervention. So if there is a mother who's with a child who's less than 6 months of age, you talk about breastfeeding. You talk about interventions that are there. When the child is there about 6 months to 1 year of age, you talk about complementary feeding. You take about how do you take care of child, what are the other interventions. So we designed specific messages around mother and child to be provided during that entire thing. That 45 minutes of interaction when an immunization person is there the 15 to 20 minutes of wait before the vaccination and 30 minutes of wait after the vaccination was used to the best optimal things. Every child who was identified was referred. It was not lost in transition. It was these children were referred to different places so that they can continue with these services. These things were also used in emergency. We used this platform in cholera. So the same immunization platform disseminated messages around how do you prevent cholera, how do you identify cholera, cholera vaccine. Same thing was used for COVID vaccine and for hepatitis A. Then it was all digital. We use digital systems so that the data entry doesn't become a burden. The data things that are coming in get recorded on one place and then move across. And finally, this was a place where social and behavior change communication came together. You change behavior, and when we're talking about gender, this becomes a platform where you can have those discussions. These are the places. I will not go inside it. These are the interventions and this, but just to show you what were the results. So in this intervention that we were able to do, we were able to vaccinate 250,000 missed children and adolescents. But this was our primary target. But beyond doing that, we were able to identify SAM and MAM cases from that same community. We were able to identify out-of-school children and then refer them back. We were able to reach the Haddi children, the most vulnerable children. We were able to reach extensive numbers of parents with MNCH, with COVID-19, with cholera. So this story actually tells you how immunization can be an entry point, and it proves that there is no additional penny that we spend. We use the same resources that we had to spend to reach that child, but we used it in a way where it linked across to all other interventions. So key takeaways, this is my last slide, is that integrated services, there are very clear interventions that can be integrated. When you integrate these services, the cost of delivery gets reduced. The acceptance of parents was extensively well, because if I go across with a need, but there is no other platform, so when a disabled child came across, we were able to link that disabled child to somebody who's providing services. So that was a very clear intention and a very clear incentive for parents to move across. And finally, I will say that integration is not something that you can mix up. Every program has its uniqueness and everything requires. What we did was we brought across clear nuances where immunization can support, but not become, we didn't wanted immunization to replace a PHC. No, that was not. But it became a very clear interaction point where this can be taken it forward. All of this led to an approach that this is the initiative that the government has now taken over. This will be the way that immunization is taking it forward. And we are expanding it to not just public health programs, but public health programs and beyond. We have a publication that is going on. If you search across immunization as an entry point and frontiers, you will get the abstract on there. And this month, the paper will be live. I would request you to read it across. And thank you so much.
Thank you, Dr. Bhrigu. I think definitely two very complementary presentations. One speaking about why there is a need for integrating and just profiling the kind of children and the genuine correlation and the lack of access to services. And I think the second was, I think the Lebanese example is a very concrete example in an extremely challenging circumstance and context on how you can implement such an integrated service. Happy to dive right into audience questions if people have any. Feel free to jump in. 1, 2, 3, 4.
Thank you so much for the presentations. My name is Tosin Ajayi from Chai. I have a question each for each of the presenters, starting with Dr. Chizoba. I think my question was around, given the low overlap between the children, the zero-dose children and the children with wastage, I'm quite keen to understand your reflections around the need for integration for that particular population. I completely agree with the need to kind of focus your energies around where there's greatest need. But I'll be keen to understand how, if there's such a small overlap, is there still a need for integration in the context of Madagascar? And I'm also quite curious to hear if you found any linkages between wastage and under-immunization as well in Madagascar. My second question is for Dr. Kapuria. Thank you so much for your presentation. I was quite interested to hear about how you're using the integrated approach in Lebanon. And would be keen to understand the staffing model, because I think I see you adding quite a lot of services to the same healthcare workers. And I'll be keen to understand if there were any strategies that you implemented around not overburdening the healthcare workers. Thank you.
Thank you, Tosin. Very astute question. So the way we look at it is this. We looked at whether or not there was an overlap between zero dose and wasting in the individual child. And that's the one where we had only 2.2%. But when we looked at in a region whether or not children are either zero dose or wasted, we found that in almost half or so of the districts, about 30% of the children are either zero dose or wasted. Now, those kids, all kids should have immunization services, right? So if you provide immunization services and integrate with nutrition, you're going to get the children who have wasting and stunting as well. So the fact that you have a high prevalence of both conditions, I think is good enough reason for us to integrate, because number one, immunization gets to everybody. And then, things like malnutrition or child health services now are for a subset of children. So that's the way we look at it.
Thank you. Thank you for raising a very pertinent question. The staffing thing, this entire approach at the community level was done with a team of 3 members, a nurse aide, and a community health worker. So these were the 3 people who used to come across, because in Lebanon, the vaccination can only be done by a nurse. That's the regulations that are there. So the nurse was there, a nurse aide was there, and community health worker, community health volunteers were there. And we mobilized the municipality to come across and support this intervention. And we very clearly divided the role between them, so that once you reach this station, what will be done? So at the point of registrations, these questions were already clear, which were going inside it. When it goes to the nurse aid, what was happening? So you have a very clear stagnated process, and it was divided between pre and post vaccination, so that it doesn't impact. That's how we rolled it across.
Yeah.
I have a mic already, yeah.
Oh, I'm sorry. Just after her.
Okay.
Thanks.
Thank you very much for the 2 excellent presentations. My question is for Dr. Kapuria. Thank you very much. So in the model with the 7-prong petals and the interlinkages, I'm particularly interested in the one, how were you able to coordinate with the other services? Was there some sort of pre-existing agreement? Did you have some negotiations in place for them to be part of that referral, the network, and to anticipate that this would essentially be more systematic and would be scaled up prior compared to what was happening previously? So that is one. The second question is looking at where you have the social protection. I think you called that the HADI. It seems there's an assumption that these children have been mapped and documented somewhere. And so that was the basis. So could you clarify, is there some registry that is updated that identifies those that are most vulnerable within their communities? How are these updated? How are these assessed by your program? If that's not the case, could you share how those children and communities are regularly identified? My name is Falake Olainka, and I work with USAID, Washington, D.C. Thank you.
Thank you so much. Let me start by answering the first question on coordination and integration. As I said, this was not the design. The design was to go out, do vaccination of missed children, come back. That was the design, and that is what we were implementing in the first 6 months of 2022. But when we realized that these are the opportunities and these were the needs at the community where the program can do, we slowly started moving it across. So we started with the nutrition. So nutrition was one of the components that as UNICEF, we were part of the nutrition program. So we decided and have that integration of what can be done, created interlinkages. Then we started on education. So it was a gradual scale up built across. We very clearly defined as to what is the level that we can deliver. What is the level? We don't want to compromise on immunization. To be honest, this was that we don't compromise the situation. So we defined the level of interventions and we defined the level of handover. When a child is identified, it is not lost in transition. So we had a very clear data sharing mechanisms that when this child is identified, these were the data that will be available to you weekly, monthly, whatever is the frequency. And then that team starts taking over. So if there are out of school children, we had a very clear name, phone numbers, addresses, locations that were provided in confidence to the teams who are following up for out of school children. Then these children started following it up across. So that were the interlinkages that we created over time. And then we realized that it was a win-win situation for both the programs because they also wanted to reach those communities. What we also did was heat maps. We also did was if there are high number of malnourished children being identified in one particular area, the mapping of those children gave across that this area has a major problem. Out of school, these areas have a, so the other partners who are working inside these can also focus their interventions in those particular areas because you now know what is happening. We were reaching out to every child. So that was the strategy of integration. It slowly developed over the time. And now we have very clear, robust, clear roles and data sharing mechanisms so that these childs are communicated. The second is on social protection. You are absolutely right. And on the social protection, it is not something that you can discuss of child abuse sitting on a session with 20 mothers and things. So we use the opportunity of social protection or child protection in this opportunity to appraise because we are reaching to the most vulnerable. So we use this opportunity to spread the information about all these things into a storytelling method rather than going and screening every child because that was not the intention and that you cannot do in this kind of a setting. That is my last slide, that there are limitations, that things that you can do across. But what we did was we created awareness on these messages where teams who are working on social protection take it forward and built it across that. So it can improve reporting, it can improve access because there we talked about if something is happening to you, you can reach out this way. So it was not child to child or those kind of interventions, but it was more of awareness on the social issues. I hope I answer your question.
Our last two questions, one to the gentleman there and one to you last. And please limit yourself to one question, please. I'm really sorry. We have the next session coming in pretty soon.
Okay, thank you. My name is Yotu. I'm immunization specialist from UNICEF Papua New Guinea. Some of my questions are already covered by the lady, so I just highlight one question specifically. So, what are the drivers for successful integration of these health services? Because understanding that other country context as well as the Lebanon situation, when you arrange this type of integrated services, you also need to ensure commodities or supplies are available, and also staff are trained and oriented. So how did you organize that and make sure all these commodities, supplies are available so that your integrated service is effectively implemented? Thank you.
Thank you again. Again, this was part of the planning process. So there were very clear commodities. You need MUAC tapes. I didn't talk about it. We did micronutrient distribution. So there were micronutrients requirement. These were the process because we very clearly know that in these target populations, what is the anticipated number of missed children that we're targeting across. We worked backwards with our partners where these commodities are coming to ensure that there is a regular supply of these commodities. We brought them inside as a package to say, when we are doing a sessions, we will ensure that all these pieces, the vaccines are there, but beyond that, the micronutrients are there, the MUAC tapes are there. We have multiple other pieces. I was not able to present all the details. We had number of interventions on social and behavior change communication. So all these pieces, we designed it at the level of session. So it was based on, if we are doing this kind of a session, this kind of commodities are required. And so we did a kind of logistics planning for that, interacted with them, secured some funding to get these interventions, and then take it forward.
Thank you very much for the presentations again. I was just wondering for, the success story of integrated services. I think it's very important, reducing the missed opportunity to vaccinate the children and so on. I think it's great. Now, concretely, at country level, when we look at the conditionality for getting the grants from donors, Gavi, etc., integration is one of the critical points, and we need to document to which extent integration is currently in the regulations, like strategies, policies, whatever. It's one. Then the second point is the implementation, to which extent this is implemented. So I understand in Lebanon is something like there is no governance really and so on. But I assume that the technical programs in the Ministry of Health are quite, working. And my question is about the measurement. What is the added value of integration? Did you measure the increase of immunization coverage and equity because of integration? And I would be super interested in what are the metrics for you to measure the success stories of integrated services. Thank you.
Thank you so much. Again, first is on the Ministry of, the entire program is led by Ministry of Health. So this is driven by the Ministry of Health. I present on behalf of Ministry of Public Health. So even though there is a caretaker government, the Ministry of Health still takes the ownership of running the program. And in the immunization program, it's very essential that we do not differentiate between a host community child and a refugee child. So the immunization program applies an equity lens and says, we don't even talk about which child, which community it is coming from. So that is the lens that the Ministry of Health is applying on that. On the matrix of success, the first metric on success is our missed children that we wanted to reach. So that was our target. That was the rest of all the things were add-ons. Okay, but these add-ons that were part of it, where we talked about reaching to the children who were malnourished children, out of school children, these were incentives that were added inside the program. So the metrics still remain on missed children and the reach of the missed children. That was our major matrix, and we were able to achieve that. The other piece that is there was no, what we are now doing is an implementation research to identify, does parents value the other pieces? Because what we realize is that when a parent got a service which was needed for that child, and I can quote you with the very personal example, there was a child who came for vaccination who very clearly needed a wheelchair. We connected that with this. The next time when we reached out to the community, there were 4 other children who were physically disabled, who were part of the sessions to come across, because they realized that these services are not just talking about those, they are linkaging across. So those were success metrics that we have brought across. We are currently documenting that as part of our paper, and there will be pieces inside it.
Thank you. Let's wrap up the session if you'd like to respond.
I just wanted to add to the answer. I think in terms of measures of integration, of success of integration, you can measure the primary outcome that you're interested in, which is, let's say, immunization coverage. You can also measure the uptake of the additional services, right? In his case, things like the whether or not more children are now being referred to child protection services or the other ancillary services that were integrated in the program. So it would require you looking at multiple sources of data and then comparing time trends over time from when you started integration to after integrating.
Thank you. Clearly, time is running short here. As always, if you have more questions, feel free to bump into them intentionally or non-intentionally and ask them any questions. Maybe 30 seconds, quick last word, last statement. What do you want the audience to take away walking out of this room?
For me, integration is not a question of should you do it. It's really a question of let's find out how we do it best and get on with it, because most children will want wraparound services. So integration is really that antidote to siloed service delivery. So let's go forward with integration.
And I'll say that immunization is a program that reaches the most number of children. If immunization cannot reach, cannot integrate, or cannot be an entry point, then no other program. So we should use the opportunity of immunization program to have that access and that trust of people and to deliver more and more. This will make immunization program more stronger. And that is what we have felt. This will strengthen immunization program when we bring in a host of services together. So I think it's a doable thing. It's a doable model that we have demonstrated, and let's try it out.
Perfect. Thank you, everybody. Round